A blessed evening to one and all. I am greatly delighted to welcome one and all to yet another session of Cardio-Obstetric Masterclasses, the fifth Cardio-Obstetric Masterclass, with yet another complex and important topic for discussion today, Fontan pregnancy. I now request Dr. Justin Paul, the course director, to share a few words on the Cardio-Obstetric Masterclass and today's session.
A very good evening, all of you. It is indeed a great pleasure to welcome all of you to Cardio-Obstetric Masterclass. So this idea of bringing cardiologists and obstetricians together in one forum is very important for our nation to improve the cardiac contribution to improve the maternal mortality of our nation by reducing the cardiac contribution to maternal mortality. So when cardiologists and obstetricians sit face to face with each other to discuss the problems of cases and bringing in the other specialists involved like anesthetists and cardiac surgeons, it really helps to improve the outcome. So with that idea, we started the Cardio-Obstetric Masterclass, and we have been trying to discuss complex cases. So every time we learn from the previous meetings from the faculty and the panelists and their teachers, and we are just modifying accordingly. This time, we are discussing a case of pregnancy after Fontan surgery. And our panelists and speakers and panelists, Dr. Annie will introduce. But however, today we couldn't have a cardiac surgeon who's still held up in a pediatric cardiac surgery. Is still ongoing. So probably if he may join if the surgery gets over. It was an emergency. He had to log in all of a sudden. So the other panelists are all here. Today we'll be having a case of Fontan's when going for pregnancy. First, we'll have a small presentation about the hemodynamics of Fontan and how hemodynamics of pregnancy, how they interact with each other. Then we'll have the case presentation. And finally, we have a 10 minutes take-home message as well. And now you can introduce the speakers and the panelists.
Thank you, sir. So I'm happy to introduce the panelists for today's session. Dr. Manoj Challani, Chairperson, Medical Disorder of Pregnancy Committee, FOGSI, Managing Committee Member, ISAR, Chairperson, Research Committee, GC Chapter, and his name has been inked in the Golden Book of World Records for maximum number of embryo transfer in 3 hours. So with a lot of publications and he being the chief editor and peer reviewer in Journal of South Asian Federation of Obstetrics and Gynecology. Dr. Nageswara, Chief Pediatric Cardiologist, Rainbow Hospital, Hyderabad. He's a recipient of numerous awards, including the American College of Cardiology Award, the Usher Endowment Award, the Dr. Y.R. Reddy Gold Medal for Best Paper Presentation, etc. And he's participated in various conferences, both national and international, and conducted a lot of workshops and delivered guest lectures. So he is experienced in complex interventional procedures, including neonatal valvotomy, stenting of ducts, and hybrid procedures like periventricular device closure. As Sir has told, Dr. Robert Sir is not at present able to join us, but Sir is a pediatric cardiac surgeon in MIOT International, and he's known for his expertise in neonatal and complex congenital heart surgeries, valve repair surgeries, and minimally invasive cardiac surgeries. Dr. Sumitra, Senior Consultant Anesthesiologist and Anesthesiology and Pain, Madras Medical College. She plays a great role in perioperative nerve blocks for intraoperative and postoperative pain relief, high-risk obstetrics, BLS and ACLS coordinator. And now I would like to introduce the presenter for today. Dr.Navaneetha Sasikumar, Associate Professor, Department of Pediatric Cardiology, in charge of Adult Congenital Heart Disease Services, Amrita Institute of Medical Science. She has successfully established a pediatric cardiac and interventional program in public sectors, teaching hospitals. She is actively involved in foundations helping children with heart disease and has developed the Smiling Heart app to improve the availability of pediatric cardiac care. Recipient of the 2022 Escalator Award in the research category, award by Women as One, the US-based organization supporting women in cardiology. She has more than 25 publications and authored more than 10 chapters with multiple paper presentations in international, national cardiology and pediatric conferences. So I welcome one and all. And before we move into the case presentation, we'll now have a short discussion on the hemodynamics of pregnancy in Fontans by Dr. Nageswara. Over to you, sir.
You can share your slides, Nageswara.
Good evening, all, and I thank Dr. Justin Paul and for your kind introduction, Arnie. And Navaneetha is going to present a case, and we'll have more discussion. I would like to give just a brief introduction about the Fontan. From the obstetric point of view, this kind of procedure is being done in cases where we cannot do complete correction of any of the heart disease. So any condition which has got only one ventricle, either morphologically or physiologically, then we will do a procedure called a Fontan procedure, where superior vena cava is connected to the pulmonary artery and inferior vena cava, with the help of an extra cardiac conduit at this point of time, is connected to the pulmonary artery. So you have a passive venous circulation is bypassing the right heart, that is right atrium and right ventricle, directly connected to the pulmonary artery. So if you take a normal human being, normal individual, the blood which is ejected from the left ventricle will go to aorta, from there to the systemic circulation, then capillaries, then again the venules, major veins to right ventricle, pulmonary artery, right ventricle pumps into pulmonary artery, then pulmonary vascular bed, pulmonary veins LA and LV. This is what the normal circulation, whereas in Fontan, you don't have subpulmonary ventricle, there is no right ventricle. So therefore, the forward propulsion of blood from the systemic venous return from the right ventricle into pulmonary artery will not be there. It has to dependent on the suctioning power of the left ventricle. As the age advances in a patient with Fontan, or any kind of insult or injury or any kind of hemodynamic challenge, typically like a pregnancy, there will be over circulation, increased cardiac output physiologically, increased heart rate. So the suctioning power, it appears theoretically, will be reduced. So therefore, there are theoretical chances that some kind of a compromise on the Fontan circulation is possible. So what will happen to the patients with the Fontan? So Fontan is being done to the single ventricle patients. There will be reduced forward flow by the ventricle, and long-term issues like a chronically elevated central venous pressure, a passive pulmonary circulation, and exercise limitation. Sometimes we create a hole called fenestration, may lead to systemic desaturation. This is the typical example of a case of tricuspid atresia. The tricuspid wall is completely fused. There is no blood coming from the right atrium to the right ventricle, which is small, and the left ventricle is the only ventricle. You can see the MRI picture, which is dilated, which is taking the whole blood and then pumping into the systemic circulation. The long-term complications include a chronic passive systemic congestion, which may be risk for arrhythmias in atrial, or sometimes electrical excitability will be there, hepatic congestion, and there will be depressed resting and exercise cardiac output, preload deprivation of the univentricular heart, thrombophilic tendency, bleeding propensity. All these are various complications are noted in adults as the age advances, 4th or 5th decade. So if you look at pregnant women here, you all know the challenges with normal physiological pregnancy. The heart rate will be increased, the cardiac output will be increased, contractility will be increased, RBC volume will be increased. So what will happen in a normal human being, normal pregnant lady? there will be volume overload situation. The right ventricle will distend and will increase the preload, will get more preload. It will eject into pulmonary circulation. So your cardiac chamber sizes also will be increased. Superior, the SVR, systemic vascular resistance, will be reduced. At the capillary level, more perfusion will be there, more cardiac output will be there. It is like a hyperdynamic circulation. Whereas in case of Fontan with pregnancy, the blood which is coming from the vena cava will not be ejected into the pulmonary artery because there is no ventricle. Whatever the mechanism which is going to be by the ventricle, systemic ventricle, which is going to do suctioning action into the left atrium, left ventricle, and output. Suppose you have a tachycardia, the diastolic function is very important. In case of pregnancy, second, third trimester, because of the increased heart rate, the diastolic time interval will be reduced so that the flow from the pulmonary veins to the left atrium and then subsequently to left ventricle will be compromised. Therefore, the cardiac output, which is supposed to become double, may not achieve to that extent. The enteroplacental flow will somewhat compromise, somewhat reduce. So these are all changes that can happen in the second and third trimester. And during delivery, sometimes there will be increased in CVP, and also the full-term pregnancy fetus will cause compression on the inferior vena cava, which suddenly, when we deliver the baby, there will be acute relief of a compression, so that preload will be increased to the systemic veins. However, there is no right ventricle to cope up with that circulation. So, moreover, the volume overload will be increased close to 200 ml because of the acute contraction of the uterus immediately after the delivery. So, all these physiological changes are going to happen immediately in the peripartum period. So, if you look at the pregnancy and then some complications, the arrhythmia rate, heart failure rate are somewhat significantly increased compared to the Fontan with normal pregnancy versus Fontan TCBC and pregnancy. Similarly, peripartum, postpartum hemorrhage, and also premature rupture of membrane, all placental hemorrhage, because most of the patients either on oral anticoagulants or echo or aspirin will be there. So that particular publication, which came in circulation, gives some kind of information how these complications can happen based on their ventricular function, systemic desaturation, and arrhythmias, and also patients who are on oral anticoagulants and aspirin. So these are all various maternal complications. So WHO risk category, which is considered as class 3 in some of the cases, even if it is a good Fontan, we should be careful when we are planning a pregnancy. So preconceptional counseling is very important. We need to explain some of these things before they conceive. So thank you very much. I think we'll allow Dr. Navaneetha to present, and we'll have more discussion. She may be having more slides to talk. Thank you very much.
Exactly. I think Dr. Nageswara, thank you very much. You did a great job of simplifying it very nicely and putting it across in such a way that even MBBS doctor can understand the Fontan physiology. Now, we'll request Dr. Navaneetha to present. Dr. Annie, you are sharing the slides? Or Dr. Navaneetha is sharing? So as Nageshwar explained, this is a circulation in series. Unlike the routine normal phenomena where it is a parallel circulation. Yes, I think you are visible now. You're visible.
Yeah. So, very good evening to one and all, and sincere thanks to Justin Paul sir and his team for engaging us in this cardio-obstetrics session. And thank you, Nageswara sir, for that wonderful introduction to the topic. I have Dr. Pranati Toshniwal with me. She is our final year Pediatric Cardiology DM fellow, and both of us together will be presenting. Some parts of the presentation she'll be doing and some parts I'll be taking over. So without wasting much time, we'll go into the case.
Good evening, everyone. I'll be presenting this case of pregnancy after Fontan surgery. So the basic diagnosis of our patient is double outlet right ventricle with a non-routable VSD, severe pulmonic stenosis. Left Glen shunt was done in 2004 at 8 years of age at another institute. And extracardiac fenestrated Fontan was done in 2012 at 16 years of age.
So, in addition to the usual situations where Nageswara sir had mentioned regarding single ventricle, in certain situations where although there are two ventricles, when a two ventricle repair is not possible, like in this situation, we have to resort to the single ventricle pathway, despite the fact that the ventricle there may actually be two ventricles. So this is such a situation that where the patient actually has two ventricles, but because of the anatomical peculiarity, we were unable to do a two ventricle correction and hence finally underwent a single ventricle palliation in the form of blend as the first stage. So when the superior vena cava as well as the inferior vena cava both have to be connected to the pulmonary artery in the final palliation. This is not done together. It is done as stages. So in the first stage, the gland will be done where the superior vena cava will be anastomosed to the right pulmonary artery. That is generally done somewhere between 6 months to 1 year of age. And then around 4 to 5 years of age is the usual time of Fontan completion, when we connect the inferior vena cava also to the right pulmonary artery. So in this patient, we can note that the first surgery itself was delayed. It was done around 8 years of age. And the second surgery again was at 16 years of age, which is slightly unusual in today's times, when mostly it is done around 4 to 5 years of age.
So the patient was first diagnosed during infancy. Glenn was done at 8 years of age in 2004, followed by Fontan in 2012. She got married at 25 years of age in 2021 and had her first pregnancy in 2022. Until 2019, she was regularly following up with us. Due to COVID, she could not follow up for 3 years. During her 2019 visit, she was asymptomatic and in NYHA class 1 with a saturation of 94%. She was initially on aspirin and warfarin from 2012 post-Fontan surgery till about 5 years after Fontan, after which warfarin was discontinued. Her ECG in her 2019 visit was in sinus rhythm. Echo showed a well-functioning Fontan, open fenestration, normal ventricular systolic function, and no significant AVVR.
So the fenestration is something that the surgeons do during the Fontan operation, particularly to help the immediate post-operative period. So they put a hole in the wall of the Fontan conduit, which enables some communication between the conduit and the actual atrium of the native atrium of the patient. So why this is done is in the immediate post-operative period or whenever pressure, which is not good for the Fontan, the fenestration can shunt from right to left and relieve that pressure. So that helps, particularly in the immediate postoperative period. What happens mostly is in many patients, it just closes off on its own. In some patients, it may remain. Our usual practice is that unless it is not troubling the patient in the form of significant desaturation, we just leave it alone. So if the patient has significant desaturation either at rest or with exercise due to a penetration, then we have a protocol of assessing whether that needs to be closed or not. And then if the patient successfully passes the test occlusion, then we close it. In this patient, what happened was that she was absolutely fine. Her saturations were okay, and the penetration was still open. So there is some, controversy as to maybe leaving the penetration open long term may be beneficial for Fontan. So we follow that philosophy, and what we do is, unless it is not troubling the patient, we leave it open. So that is why this patient has a open fenestration, which is part of the Fontan circuit as such.
Thank you, Navaneetha. Are you presenting the discussion break slides or the earlier slides you're presenting? Yes.
Let me just check, sir.
Because there was supposed to be a small discussion break before the slide.
Oh, is it?
No issues.
So she has just sent it to me right now, sir.
Yeah, no issues, no issues. So what we
I will just do it now, sir. 1 second.
Yeah, shall we do the discussion now?
Yeah, please, sir.
Yeah,
By then, I can get the other slides.
Yeah. So now thank you, Dr. Navaneetha. As we can see right now, we have a patient, say we'll go back to 2016, where the surgery just got completed. The surgeon has completed the Fontan's completion. Both IVC and SVC are connected. And the patient is for discharge at this point of time. So we will like to get the cardiologist's advice, the cardiac surgeon's advice, and the obstetrician's advice at this point of time. So what will be the advice that you will be giving to this patient? Dr. Nageswara, can we get your views?
Any patient who underwent either surgery, palliative or definitive, especially in the Fontan situation, we have to really check the functional class and the systemic saturation. Because when fenestration is there, if systemic saturation lesser than 85%, there is a loss. Then second is ventricular function is very important. If the ventricular function is good, then tolerance of pregnancy is going to be reasonable. Third is electrical issue. History of any arrhythmia is there or not also is important. Fourth is medication.
What I asked is 1 minute. This patient right now, you are discharging from the hospital after completion. So what will be the advice you will be giving this patient when you are putting them away?
I thought you were asking for the pregnancy
She's 16 years old.
Fine.
With the Fontans and you are discharging her. So what will be the advice we give to them?
When we are discharging this particular patient, we have to make sure that what is the category. Most of the times in the first 6 months to 1 year, we'll start the oral anticoagulants and keep INR 2 to 2.5. So we have to tell her that she is going to take oral anticoagulants, that issue. Second is, if there is any issue of palpitations or any issue of signs of Fontan failure in the form of edema or functional class deterioration, we have to check that. So therefore, follow-up assessment is going to be critical, like what I enumerated before.
Thank you, Nageswara. Now, we don't have the cardiac surgeon today. Anita ma'am, can I get your opinion? Thank you for filling in the last moment as a panelist. So she's a 16 years old lady, and she is, in the adolescent to womanhood age group. Likely to, these women often they get married early and they tend to get pregnant and all that. So what will be the advice, madam, you will be giving? Probably if you can cover the cardiac surgical perspective as well, it will be helpful.
Thank you, Dr. Paul, and thanks for having me on the show. It's a very interesting case. I think the most important part that we should remember about Fontan is at whatever age it has been done, it is going to be a palliation. And therefore, the parents need to remember that this is, or the family, this is something that's not going to go away, and therefore they need to come for follow-up. And I think what has happened in this case is that for some reason, I think she's kind of not come for follow-up. And I'm not saying that we can prevent all the complications, which Dr. Nageswara has enumerated, because practically everybody goes through those complications. But what we can do is we can probably postpone them by timely intervention, timely advice. So the first advice to anybody who is going away is that they must come for a regular follow-up, and there are clear-cut protocols as to how to follow up. All needs to be seen. The second thing is what kind of Fontan has she had? I think Dr. Nageshwar has touched on, the picture that he showed was an extracardiac Fontan, and this lady has also had an extracardiac Fontan from what I can make out. But we are seeing lots of women in the child age group who have had either classical or lateral tunnel Fontan, which used to be a routine procedure that used to be done, let's say 20, 25 years ago. So the kind of Fontan that she has had is also important, because the complications are supposedly less with extracardiac than with the usual that we used to do earlier. The third point is about fenestration. I think Navaneetha has really talked about the indications of fenestration closure, and I entirely agree with her saturation being 94%, but I would like to see what happens to her saturation on exercise at 16 years, 17 years, 18 years, to be very sure that she's not desaturating enough. If she is, then again we need to think about closing the fenestration. Thank you, Dr. Paul.
Thank you, madam. Dr. Manoj, now as an obstetrician, what concern that you will be having, and what will be your advice to this girl who probably is likely to get married over a period of time and be sexually active as well?
Yeah. So she is 16-year-old, but one day she will get married. So it's very important at this stage we counsel her. First of all, there will be little bit difficult in getting pregnant, because it affects ovulation also. Secondly, we have to caution her and her parents also that pregnancy won't be so easy. So there will be maternal complications as well as fetal complications. There may be preterm labor, there may be IUCR, and as far as mother is concerned, there may be PH, antepartum hemorrhage, plus cardiac problems may be there. So very important is, once they are planning to conceive, they should visit the cardiologist and obstetrician. And as soon as she gets pregnant, she should again be in regular touch with the obstetrician and cardiologist. So that is very important. So we have to counsel, we have to tell them it won't be a normal, the journey won't be so smooth. So they have to be really cautious about it.
Thank you, Dr. Manoj. I think all the panelists highlighted the importance of telling the fact to the patient that it is not a one say go and everything is over, you can leave. No, they have to be with us. It has to be a tough journey and long journey. To make it long and smooth and comfortable, they need to be with us, coming for regular follow-up and regular periodic evaluations and consultations. I think you all touched very well. We'll go back to Dr. Navaneetha. You can continue with the case. And there will be 2 polls after the, I think, next 2 slides probably. You can go ahead, Dr. Navaneetha.
Yeah.
Audience, please be ready for the poll. There'll be some polls we'll be asking. At that point of time, you can, make your choices.
So, during this visit in 2022, when she had come to us at 16 weeks of gestation, she was in NYHA class 2, had history of recurrent headaches with minor alterations in the sensorium. There was also history of psychological stress at the marital house. She was on aspirin and folic acid at this point. Heart rate was 100 beats per minute, saturation of 94%. ECG was in sinus rhythm. Echo was similar to the previous echo, which is in 2019, except that this time there was moderate right AVVR and trivial left AVVR.
So can you launch the poll? Team Monica, Dr. Monica, can you launch the poll now?
Yes, sir, it's done.
Yeah, the poll, you can all answer. Audience, please make your choices. So now, Dr. Nageswara, would you like to just say a word about what you are seeing here?
So patients with Fontan circulation who are risk stratified as modified WHO classification 4 includes, so if the saturation is lesser than 85% or ventricular dysfunction, presence of significant moderate to severe AV wall regurgitation, either it is a common AV wall, left AV wall or right AV wall, presence of refractory arrhythmia, protein losing enteropathy, all of the above.
So I think, thank you. I think it's a really reassuring to see that everyone has answered, almost everyone has answered, right? All of the right answer. And Navaneetha, you can move forward. You can stop the poll.
So I would like to highlight that our patient this time has symptoms suggestive of prothrombotic tendency with an open fenestration, has worsening AVBR and worsening NYHA functional class.
So now we'll just give a poll here again, launch poll 2. And then we'll have a discussion with the panelists on the poll 2. Can you launch poll 2?
So what would be appropriate in this particular patient? Option 1, advise termination of pregnancy. Option 2, advise continuation of pregnancy. Maybe option 3 also we should have given that reassessment after 2 weeks because patient is falling in the 16 weeks category. Because it's early first trimester, you can wait till second trimester also, probably.
Okay, okay. So now I think we'll ask the discussion. I think we have sort of 55-45. A slightly larger majority of them will like to continue the pregnancy, and they're sort of evenly distributed. So now let us take the help of the panelists here at this point of time. How will you triage this patient, and what will be the counseling that you're going to give for this patient? And what will be your assessment plan if you decide to continue pregnancy?
Sir, one thing is, I observed this patient that she has come in 16 weeks, which is, very late. Like as we discussed earlier, that close monitoring should be done. She should visit the obstetrician before the pregnancy and as soon as possible. So the NT scan should have been done at 12 to 13 weeks of pregnancy, which is best. So suppose there is some problem with the NT scan, we can do some, we can take some decisions and then we can proceed further. So that is one point which I found in this patient.
Okay, okay. Maybe I'll get Anita ma'am's advice here. Anita ma'am, would you like to comment here, please?
Yeah, I think we would want her to terminate pregnancy because she really falls into the class 4 WHO, modified WHO risk class, because she has moderate AV regurgitation. To me, it is something that is likely to worsen as the pregnancy advances. She's already class 2. She has some symptoms, and of course, she's 16 weeks. So she's probably going to get worse with time. But having said that, I think majority of the patient that I have looked after would not want termination to be done, especially the first child. They would like to continue. I think we have to support her in her decision. And therefore, I would be quite comfortable if they decide, despite my telling them to continue pregnancy, and of course have the whole team approach that we're going to probably discuss as we go ahead. But I would be a little worried about her, and of course about the fetus, that she's likely to have higher complication rates herself as well as fetal complications.
There is a question in the box. Is there a role of exercise testing at this point of time, or a 6 minutes walk test, something like that for this patient?
I would perhaps say that something that's probably going to help will be more like BNP level rather than 6 minutes walk distance, because of her pregnancy. That may be a little, we may not get, because I don't know how is the validation done for a 6 minute walk distance in pregnancy, but a BNP level might be of some use.
Yeah. And I think that is fine. And obstetrician, I would like to ask you one more question. What will be the safe therapeutic option for abortion? Supposing the patient decides to go ahead with the MTP, what will be the better way? How will you proceed with this?
For anesthesia will be like a little bit risky for her. So like if it's she has 16 weeks pregnancy, then we can give epidural and then we can do DNC in this case.
Dr. Sumitra is our anesthetist, obstetric anesthetist. Would you like to comment here? How would you like to support and be a part of this team here when the patient decides to go ahead with an MTP? You are muted, Dr. Sumitra. You are muted. Kindly unmute yourself. Yeah.
Yes, sir. Hello, good evening, everyone. Thanks for this opportunity. So most of the times when such a kind of patient comes, knowing that this patient is going to fall into a highest category, they do not accept for termination. That's what we have seen. But if there is a plan to go for termination, even if it's going to be MTP, in practice, anesthetist will be always called for as a standby or backup just in case a medical termination does not work, or the patient needs to go in for emergency suction evacuation, or if there's any incomplete products of conception. So whether it is going to be termination at 16 weeks or a full-term pregnancy, the plan of anesthesia will have to be epidural, carefully titrated epidural with a complete workup. And even before this, we are going to have a multidisciplinary team discussion with the cardiologist, obstetrician, intensivist, and the anesthesia teams. So we need to carefully plan the date, time, and it has to be during a daytime. With all the backup of the cardiology team and the intensivist team. So workup wise, we need to have a complete CBC, RFT, latest echo, which is already there. And this patient is on antiplatelets, aspirin and warfarin.
Dr. Navaneetha, she's on warfarin. No.
She's on warfarin. She's only on aspirin. So that gives us a little bit of a solace. She's not on warfarin, and she's not on any low molecular warfarin. So if the patient, we can, even if it's going to be an emergency, we can plan an epidural, number one. And before this, I would like to also have gastro opinion to rule out any protein-losing enteropathy in terms of workup. So if this patient is going to come for a procedure, planned procedure for termination in the theater, the setup is going to be the same as for a full-term pregnancy, because the risk in this patient, even though now she's in sinus rhythm, there's a very high risk of these patients going in for arrhythmias. Any point of time, more than 70% risk of these patients going in for arrhythmias. So the plan is going to be keep the theater ready, one, with all the invasive lines, arterial BP monitoring, central venous pressure monitoring, ECG, and the saturation. Keep the drugs ready for arrhythmia management. And these patients especially are at risk of supraventricular arrhythmias. So keep all the antiarrhythmic drugs and the external cardioversion, and plan a carefully titrated epidural with xylocaine 1.5%. And also remember, these patients are at risk of air embolism. So take care to prevent air embolism. And as Dr. Nageswara rightly pointed out, patients have got already a high BP and a low cardiac output, and they will not be able to increase their cardiac output in the event of hypotension. So the anesthetic goals, intraoperative goals are going to be, we need to prevent hypotension and keep a good preload. At the same time, in the event of hypotension, we cannot go in for volume overload. So it's a very tricky situation. So keep vasopressors such as noradrenaline, phenylephrine ready. In the event of any hypotension, make sure we go in for a judicious combination of fluids and vasopressors. And once the products are delivered, if there's a need for syntocinon, give a carefully titrated syntocinon because again, that's going to lower the BP.
Thank you. Thank you,
And
Dr.
continue the monitoring in the postoperative period in a high dependency unit at least for 24 hours.
Exactly. I think it's very important to follow up the patient, follow a continuous monitoring, intensive monitoring for the patient after MTP. That's very important, and anticoagulant therapy as well to be continued in the postoperative period. Now, let us listen from Dr. Navaneetha what the story tells us.
Yeah, so we did have a long discussion with the family regarding the maternal risks, the fetal risks, as well as what can go wrong in long term, because there's not much data as we discussed about how the pregnancy related changes would affect the longevity of Fontan. The other issue is that currently she's around 10 years post Fontan. So we also discussed about the patient's own ability to be able to take care of the baby long term, in the sense that we know that, as Anita ma'am was alluding to, this is only a palliation, and the longevity of a good Fontan may be somewhere between 25 to 30 years. She's already like 10 years post Fontan. And so that also is one of the points that we discussed. In addition, this continuing care, her pregnancy care has to be at a tertiary care center, and it cannot be managed in a peripheral center. That was another of the issues because they were from a faraway place. So all these medical, logistic, long-term challenges were discussed with the family, and finally, as Anita ma'am again told, they opted to continue the pregnancy. So they opted to continue the pregnancy, and yeah, go ahead.
Yeah, so the baseline investigations, complete blood count, liver function test, and renal function tests were sent. NT-proBNP, the baseline levels were sent, which was 174. Fetal, she was asked to undergo a fetal anomaly scan and fetal echo. Neurology opinion was taken in view of the neurological complaints she had at the time of presentation. She was continued on aspirin, and she was started on low molecular weight heparin in the prophylactic dose.
Can we take a poll here now? Can you launch the poll 3? So now we have this patient. I would like the audience to give their inputs on what will be the anticoagulant regimen that you will give for this patient. You will just give aspirin alone, or will you consider prophylactic anticoagulation, or will you consider therapeutic anticoagulation? The patient has moderate to severe, moderate AV regurgitation. There is a fenestration, NIH class 2 symptoms, sinusitis. Anita, madam, I would request you to discuss this poll. If you're available.
Yeah, so I was just thinking that we should we wait for the poll to end?
Yeah, yes, ma'am. Yes, ma'am. I'm sorry.
Okay. So the majority says aspirin plus prophylactic anticoagulation. I think that would be the right choice if she had no symptoms suggestive of thromboembolic phenomena. To me, her symptoms of, although they are not very definite, and I don't think we've done any imaging to see what they are because of, but neuro opinion being suspicious, and also I think the fact that her main symptom during this time had been neurologic. So I think we should be looking at therapeutic anticoagulation in her case rather than prophylactic anticoagulation, because pregnancy itself is such a hypercoagulable state that we need to be more liberal about anticoagulation in such cases of Fontan.
Does the presence of fenestration help make us to tilt more towards therapeutic than prophylactic now?
Absolutely. I would say that if there is fenestration, there should be all the more reason, because we expect right to left shunting across the fenestration happening all the time, and that could lead on to more neurological issues. But I would say that even if it is not fenestrated, the very fact that Fontan circuit is a very slow circuit, I would give therapeutic anticoagulation at slightest of indication if there are any symptoms.
Okay. Dr. Navaneetha, back to the case with you.
Thank you. So we did consider all these points that have been discussed, and generally the indications, strong indications for anticoagulation in Fontan include thrombosis, which is prior or current, atrial arrhythmia, and the older Fontans, like the atriopulmonary Fontans, where the connection was made directly from the atrium to the pulmonary artery without an intervening conduit, and mechanical heart valves. So she did not have any of those, and we were not very convinced about her symptoms, in the sense that she did have some amount of stress as well, and we were confused whether her symptoms were really due to thrombotic events or not, and hence we had asked for a neuro opinion. So till we got the neuro opinion, we continued on aspirin and the prophylactic anticoagulation.
On thorough evaluation by a neurologist, he suspected cortical sinus thrombosis. So at this point, low molecular weight heparin was changed to therapeutic dose with anti-factor 10A monitoring. Fetal anomaly scan and fetal echo were both normal. At 24 weeks of gestation, she had followed up with us again, and her headaches had subsided after therapeutic anticoagulation. There was mild worsening of effort tolerance. Heart rate was still 110 beats per minute as it was previously. She was continued on aspirin. She was unable to take low molecular weight heparin injections due to pain and was switched to warfarin. So now she continues to be in NYHA class 2 with a saturation of 94% on aspirin and warfarin. Echo was essentially the same as before, with moderate right AVVR and trivial left AVVR with good function. The fetal scan showed unilateral hypoplastic nasal bone, which is a soft marker for chromosomal anomaly. So amniocentesis was planned. At this time, there was extensive discussion with the family, and they wanted termination if positive for any major anomaly with a court permission. Amniocentesis was normal. There was no copy number variation detected. At 32 weeks of gestation in January 2022, she had worsening of the functional class. She was now in NYHA class 3. No neurological issues. Heart rate was 112 beats per minute. Saturation of 94%. Echo was the same as before. BNP levels were also stable without any increase. Her fetal scan showed a 1.5 kg weight fetus, which was at third centile of the expected. At this point, warfarin was switched to low molecular weight heparin again with anti-factor 10A monitoring. Pregnancy was continued with close monitoring, and obstetricians and neonatologists were also involved in case of preterm labor.
Can you launch the poll 4? So do we need to do anti-10A monitoring when you're giving low molecular weight heparin for this patient with the Fontans? No. Yeah, about half of, I think 60% have answered. So as we can see that a majority of our audience believe that it should be good to do an anti-10A monitoring. It is almost mandatory. However, maybe getting an anti-10A monitoring done is not easy. It is always good to monitor and optimize the dosage of low molecular heparin with the anti-10A levels, but it's not easily available in many places, and it is not easily affordable as well. Availability and affordability is always a trouble. However, in patients with prosthetic heart valves, it is definitely mandatory to do anti-10A monitoring when we are giving low molecular heparin. So if we don't have the anti-10A monitoring, it is wiser not to use low molecular heparin as far as prosthetic heart valves are concerned. I'm not too sure if that is mandatory. If you have the facility, it is good to do it so that you can optimize the anti-10A levels. However, it is not mandatory. It is good to do it. Can you move forward? Next slide. Navaneetha, it's over to you.
Yeah.
In the last week of February, she was at 37 weeks of gestation by LMP and 35 weeks by dating scan. She continued to be in NYHA class 3. At this point, she could hardly walk around. She had a resting heart rate of 110 per minute, 110 to 115 per minute, and which would increase to 130 beats per minute with minimal exertion. Saturation was stable, was 94%. ECG was showed sinus tachycardia. Echo was again the same as before with stable BNP levels. Fetal scan at this point was showing a 1.8 kg fetus third centile of expected. So obstetric gynec.
So essentially, the obstetrics team, we had a discussion at this
Can
point.
we take a poll, Navaneetha, and then discuss this?
Yeah, sure. Okay.
And can you take the last poll?
Yeah, sure.
Yeah, what will be she's 36 weeks now. So what will be a plan? Elective LSCS and a slow epidural or trial of vaginal delivery with the assisted second stage? So now in this background, about 60 of them have answered, and 2/3 of them have felt that elective LSCS will be the better way to go about, and the rest have felt that trial of vaginal labor is fine. So we'll take a discussion break here before we proceed with what happened to the patient. So to the obstetrician, Dr. Manoj, my question to you will be that when would you like to have the delivery? She is 36 weeks now. What will be a preferred mode of delivery, vaginal or LSCS? And what will be your plans to manage complications, postpartum hemorrhage or peripartum parameters? What will you be monitoring?
Sir, I will try to postpone delivery as much as possible so that there's more maturity of the fetus and I get a good outcome. But it all depends upon the condition of the mother. And as far as mode of delivery is concerned, vaginal delivery can be done. But in this case, when we see the condition, then elective LSCS under slow epidural is important. And we will have a close monitoring so as to prevent PPH and antepartum hemorrhage. And we'll plan the delivery. We'll stop her anticoagulants. That will be my main concern.
So thank you. So you will plan an elective LSCS. Dr. Sumitra, what will be your mode of analgesia and anesthesia? And when will you like to give the last dose of low molecular heparin? Or if she was taking low molecular heparin, what are your concerns? You already touched upon some of them while discussing the MTP, so you can focus on the key points that you would like to share the audience now.
Yes, sir. First of all, I would actually pray that this patient doesn't come as an emergency. So adequately prime the patient and the team because this patient is on a therapeutic dose of low molecular heparin. So which means for initiating an epidural, we need to have at least a 24 hours window. So that needs to be planned in the first place. Second, we have to remember the anesthetic goals. One, we need to maintain a sinus rhythm, knowing that this patient is at a very high risk of developing arrhythmias. Number two, we need to avoid hypotension. Also remembering any form of anesthesia, especially so regional anesthesia, is going to cause hypotension. Third, we need to avoid these patients, as the discussion went on, are already at a low cardiac output and a high CVP. So avoid dehydration, plan it well. Third, make sure we avoid air embolism and avoid hypoxia and hypothermia. These should be our anesthetic goals. So it should be a well-planned elective cesarean during the daytime with all the backups. Number one. Number two, this patient is already very well worked up with all the things and probing and all that. So we need to have a 24 hours window of the last dose of low molecular heparin to plan on the as a first case in the morning. How will I get the theatre ready? As I elucidated earlier itself, we need to make sure everything is ready for the invasive BP monitoring, central venous pressure monitoring. Why do we need these two? One, invasive BP monitoring gives us a beat-to-beat BP monitoring so that we can identify hypotension at the earliest and manage at the earliest. Second, we can double it up as updated to a cardiac output monitoring by Edwards monitor. CVP, even though we know that it's going to show elevated CVP, it's we can study the range, the tendency, I mean, whether it's going low or high. So that will give us an idea about the volume status, even though it's not going to show us the right heart pressure. Number two, rapid administration of inotropes and vasopressors can be done. Third, if you need to do any pacing, overdrive pacing also, it can be used. So that justifies all the ECG and pulse oximetry monitoring and good filters to prevent air embolism. Third, hypothermia prevention, warming blankets. Always need to be kept ready. And in the medication trolley, make sure that all the antiarrhythmics are there, adenosine beta blockers, amiodarone, and the defibrillators should stand by. So now the patient has come to theatre. Obviously, the patient's respiratory rate, resting heart rate is already high, and with anxiety is bound to really go up. And make sure that the patient is not going into any more desaturation. Supplement with oxygen. Carefully position the patient and sighten the universal monitors and the carefully titrated epidural in a sitting position. And after she lies down, anticipate have high index of suspicion for hypotension. Invariably, with epidural, BP is bound to fall. So prophylactically, keep noradrenaline, phenylephrine infusions ready. Keep it connected. And at the even with the slightest 10 millimeters per start, is that the inotropes. In our institution, we have the practice of going for noradrenaline and infusion and phenylephrine boluses. So once the epidural is active, the surgery gets started. Make sure we give a carefully monitor the IV flows, taking care not to overload IV because they do not tolerate it well.
Yeah.
Take care of that. At the same time, cover the patient with a warm blanket. Make sure she doesn't become hypothermic because it's going to raise the pulmonary vascular resistance. Number one. Number two, it's going to help in the ERAS protocol and the recovery.
Yeah.
And then
one minute, I'll just ask Navaneetha. Dr. Navaneetha, what was your department's plan? Did you do a CVP for this lady and invasive BP monitoring?
Yeah, we had a central line and art line.
Both lines, great. And
Yeah,
Anita, you also have the same policy, right, ma'am?
Yes.
Yeah, great. Please go ahead, Dr. Sumitra.
Yeah. Yeah. Then once the baby is delivered, now comes the challenge of nephrotomics. Remember, this patient, one, is at a high risk of arrhythmias. Number two, at the third stage, these patients have got a high propensity for postpartum hemorrhage. As much as they have a prothrombotic tendency, they do have a tendency to bleed at the end of third stage. And also, remember, they are at a high risk of developing heart failure at third stage because of autotransfusion. Even though it's a minimal 200 to 400 ml, they are at a high risk of developing cardiac failure. So keep all this in mind and have a good balance of uterotonics. So in our hospital, we follow a 10 international units of syntocinon intramuscularly and keep 5 units of IV syntocinon diluted to 10 ml as a backup.
Thank you. And let me get Dr. Nageshwar's input in it. As a cardiologist, any inputs you would like to add here, Dr. Nageshwar?
This particular patient at 36 weeks, fetus is weighing around 1.8 kilograms, suggestive of there is a IUGR. So there is already some kind of uteroplacental insufficiency. So if you look at the literature and the practice, these babies can have mid-trimester abortions, stillbirths, and preterm deliveries. Therefore, extending the delivery beyond 36 weeks, continuing pregnancy is not a good option here. So, if lungs are not matured, give steroids and plan elective cesarean section because already maternal ventricular dysfunction is present. So, to avoid the complications related to the pregnancy in a compromised patient, we all practice and we prefer to deliver. We closely monitor every 1 week or 2 weeks from 32 weeks onwards. 32 to 36 is the ideal time to deliver this patient properly. And we don't practice to extend beyond 36 weeks.
Okay, thank you, Nageshwar. Dr. Navaneetha, somebody else?
Could I just add a few more points? Could I just add a few more points?
Yeah, we will have to complete the case. Maybe you can take a minute and just finish it off fast.
Sure. So I just wanted to emphasize the importance of providing a multimodal analgesia for this patient for the postoperative period, because that's very, very important for the patient to go into ERAS protocol, because we do not want to overload her with IV fluids. The patient needs to have a good pain relief as well as regimens to prevent postoperative nausea, vomiting, so that patient can go for early orals. Provide a good pain relief.
Thank you. Thank
That's
you.
what I'm saying.
Dr. Navaneetha, back to you to continue the patient's date information. Presentation, please, Dr. Navaneetha. Dr. Navaneetha, are you there? Yeah, please.
Yeah, we were trying to share the screen, sorry.
Yeah.
Yeah, so as rightly discussed, it is very clear that the patient had a major symptomatic worsening, high resting heart rate. As soon as she starts to walk, her heart rate jumps. And looking at the baby again, as Nageswara sir was saying, that the baby is more than 1.5 kg weight and already like touching 37 weeks by LMP. So we did have a discussion and decided to plan delivery at the earliest. And in view of a clear reduction in effort intolerance, we decided that it is not safe to allow her to undergo a vaginal delivery and chose a cesarean over the vaginal. And of course, she is at a higher risk of postpartum hemorrhage. So we did a plan for active management, including a low dose oxytocin drip for 6 hours. And the uterotonic availability and preference was as per the obstetric team. And we discontinued low molecular weight 24 hours prior to the CS. And we plan to watch very closely for arrhythmia, heart failure. And as already discussed, Fontan patients are very sensitive to preload, like they are preload dependent. So it is not possible for us to deprive them of volume. And on the other hand, especially during the in the peri, around delivery, the fluid shifts happen, and they are also prone for volume load. So maintaining euvolemia is very important, and we had discussed and arranged blood and all products in case it is needed.
So she gave birth to a baby girl weighing 2.2 kgs via LSCS under slow epidural. She's kept in in the cardiac ICU with invasive monitoring. She required diligent volume management. Low molecular heparin was restarted after 12 hours of LSCS in the therapeutic range, was planned for a total of 6 weeks. To prevent thrombosis, early mobilization, compression stockings were also done. Discussion break.
Big work done by your team, Dr. Navaneetha. Very tough case, but the team has managed together and have delivered successfully the baby through LSCS. Thankfully, the mother and baby are fine at this point of time. Now, I just would like the obstetrician to give inputs on what will be your advice now to the mother on contraception, lactation, any concerns?
Yes, sir. On discharge, I'll definitely put emphasis on contraception. I'll ask that now she should not plan next pregnancy and she should use contraceptives. It can be a barrier contraceptive or any other contraceptive. And she should come for regular follow-up also, at least for 6 months. That should be there. And definitely breastfeeding will be encouraged.
And cardiologist view, Anita ma'am, any comments here, ma'am?
Not really. I think hope that once she's passed the first couple of weeks after delivery, her worst is over and she's probably going to be better. But I think somebody has said earlier also that she has to look after a small baby, and therefore she needs to be supported in the sense that, again, she should be on close follow-up from the cardiologist. Whatever drugs she requires, anticoagulation, aspirin, or maybe ACE inhibitors at some point can be started. Many of these patients are also on sildenafil or pulmonary vasodilators because of the fact that their PA pressures gradually rise. So, I mean, she basically needs a proper follow-up with the cardiologist, especially for the first few weeks, so that she's able to pull on taking care of the baby as well as, of course, taking care of herself, which is a dual responsibility.
Thank you, madam. And Dr. Navaneetha, you can continue and finish off. And one question is there, you can probably address that also as you're presenting. The patient is having a condo E. Will you consider IE prophylaxis? You can continue your discussion, Doctor.
Yeah. So, yes, so where are we?
Yeah, how was the BNP and how did you monitor? How did BNP help you to plan your course of actions?
So, I just wanted to mention that, following the discussion, the patient as well as her family, including husband, was very proactive in discussing contraception, and they did actually, consent for tubal ligation during CS, and it was done during the CS. They were so open to the discussion in the midst of all this medical stuff that we were happy to encourage the discussion and do it as well. So this is her BNP trends. Actually, with the change, modification in slides, the point of delivery has moved a little forward. It is at 126 on 3/3 when she delivered. So you can see that during the pregnancy, the BNP levels were relatively stable. And in the immediate postpartum period, she did have in a couple of days a jump in BNP, along with which she did have slight worsening of dyspnea, and she required low dose diuretics for a very short period. It was just 2.5 days that we gave very low dose diuretics, and then we came off. And after that, her BNP returned to normal as well. And her last follow-up was in May 2024. She's NYHA class 1, doing well. She still has normal ventricular function. And her moderate AV-well regurg, which had progressed to moderate during her pregnancy, had returned to mild after the delivery. And she continues to have a mild AVVR. Her saturations are almost always around that 94-95 range, and it has not deteriorated any further after the pregnancy also, and her ventricular function also luckily remains stable. So if you look at long-term outcomes following pregnancy, there is not much data available regarding Fontan. There are small cohorts which have been followed up. In some of the papers, like in this one, which was published in 2020, this said that, it was relatively okay. Like although the follow-up was like 84 plus minus 48 months, there was no significant decline in functional or structural cardiac parameters after pregnancy in Fontan. But at the same time, another paper which was published in 2017. It was just 9 patients followed up for 4.8 years mean. And most of them had some or other issue, like, 5 of them had atrial arrhythmia, some had failing Fontan, thromboembolic complication, conduction disease, and ventricular dysfunction. So, the data gives a mixed message when we look at literature. Luckily for us, our patient did well and she continues to do well. And that is all from us tonight.
Thank you. And I think before we go to the last, carry home message set, there are one more there. Is it better to stop low molecular heparin 2 to 3 days before prior to epidural? In view of that, you don't need to stop for 2 to 3 days prior to epidural. You can just, when you have planned epidural low molecular heparin, you can stop 12 to 24 hours before that. And you can even continue infusion heparin, then stop 6 hours before the epidural. Any other queries, any other comments?
I just wanted to make 2 comments. One is that the dose of warfarin obviously needs monitoring, and we would want INR to be between 2 and 3, and I hope Navaneetha agrees with me on that. It's not that we can use warfarin without monitoring. So monitoring is required for warfarin also. Of course, it is much easier to get an INR compared to factor 10A level. So that is fine, but we need to keep it around 2.5, which is middle of 2 and 3. The second point I just wanted to highlight is that every time the echo report is, comes back as moderate right AV regurgitation and trivial or mild left AV regurgitation, I just want to emphasize that here, right and left AV regurgitation is the same. I mean, they have the same connotation. We should not think that right AV regurgitation is something which is less serious. This is a patient whose left and right AV valves are with the systemic ventricle, and therefore whether it is right, whether it is left, it has the same connotation. That's all the points I wanted to make.
Thank you, madam. Thank you. I think we are just right on time, and 8:50, the last 5 to 10 minutes. I'll share the slides. Are the slides visible? Yeah. Are the slides visible?
Yes.
I'm just summarizing what we learned today. 2 slides from what Dr. Nageswara presented. For those in the audience, Fontan's in pregnancy. So systemic veins are returning to the pulmonary circulation without a pumping ventricle. There's no ventricle pumping the blood. So the pulmonary blood flow is driven primarily by an elevated systemic pressure. As a result, there is a non-pulsatile blood flow to the lungs. This leads to a chronic preload deprivation of the only functioning systemic ventricle. So as a result, there is a decreased cardiac output at rest and at exercise. If you look at the age of a patient, this is a nice study done. What they show here is on top is the actual age of the patient, 20, 25, 30, 35, etc. of a normal person. Now, the chronological age and the biological age. For an ASD patient who is 20 years old, the chronological age is 20, but the biological age may be 25. Whereas for somebody with a coarctation of aorta, the biological age may be 32, even though his chronological age is 20. Whereas for a Fontan circulation, the chronological age is 64. That means that, that is the efficiency of a 20 years old person is that of a 65 years old person. So we have to have that in mind when we are dealing with this patient. This slide shows that what Dr. Nageswara highlighted. The cardiac output of a normal person can increase up to 5 times, but a best functioning Fontan can probably increase only up to 2 times, and a suboptimally functioning Fontan may not be able to increase even up to the normal level, even with exercise. This is one slide that shows the functional capacity and the survival of the Fontans. As you can see that the earlier data showed the long-term survival up to 74%, but with the later the extracardiac tunneling, the survival is increasing. Currently, the 30-year survival of Fontans is approaching almost 85%. This shows that many patients who had a Fontan are likely to become pregnant, particularly or desire pregnancy, and the role of cardiologists and the obstetricians in their life is likely to be larger. Now, what is going to happen here in Fontans and what is going to happen in pregnancy? In Fontans, there is an elevated central venous pressure, a reduced functional capacity, and cardiac arrhythmia are common. Thrombotic tendency is common. Bleeding tendency is common. What about pregnancy? Almost the similar situation here. The increased preload, an increased cardiac output, a proarrhythmic state, a prothrombotic state, and bleeding tendency. Now, when these combine together, you find that the arrhythmia increases, the thrombotic tendency is more, the bleeding tendency is more, and an increased cardiac output at a reduced ability to tolerate more, an increased preload with an ability to tolerate less ability to tolerate is going to be difficult for the patient. And as I think our panelists pointed out, the likelihood of a successful pregnancy is very less. And it shows that 26% of the Fontan patient never could conceive. The fertility rate, not only in women, but also in men with Fontan, is less. So what are the difficulties in a pregnant woman? Getting pregnant may be difficult. Cardiac arrhythmia, heart failure, very common complications, and bleeding, thrombosis, and neonatal mortality and complications are high. But this lady, I would like you to remember, her name is Mary Canobio. She is a nurse. She is the first one who published the outcomes of pregnancy after Fontan. Till such time, Fontan was considered to be a contraindication for pregnancy. She said that the tendency to routinely discourage pregnancy in Fontan may need to be reconsidered based on her study of 33 pregnancies in 14 women, where at least 15 of them could achieve live births. I just will quote one very large meta-analysis of 255 pregnancies in 133 women, where 115 had live births. There was no maternal deaths. Surprisingly, if you find that in the literature, I could not find a single maternal death in a patient with Fontan. That does not mean that Fontan's pregnancy, the mothers never die. Probably it is never documented. But at least in the large series, the reassuring fact is that the maternal deaths have not been reported. However, the complication rates are high. The maternal complications, particularly arrhythmia, as all our panelists highlighted, is high. And the fetal complication, the likelihood of live birth is only 45%. And lower is the saturation, lower is the chance of a live birth. And this was one proposed risk stratification for Fontan into a low risk, intermediate risk, and high risk. If you look at the low risk group, it is fine. Our patient definitely is not in the low risk group. To summarize, a patient with the poor functional class, a ventricular systolic dysfunction, or a diastolic dysfunction with heart failure, severe aortic valve, AV valve regurgitation, whether it's left or right sided, significant hypoxia with less than 85% saturation, and refractory arrhythmia and protein losing enteropathy, they all belong to high risk. So in the preconception, to say that we need to have a detailed history, review the medications, arterial oxygen saturation, baseline laboratory studies, ECG, a detailed echo, liver evaluation is extremely important. So be watchful about arrhythmia. Atrial arrhythmia are very common. This could be related to underlying hemodynamic issues as well. They lead to stasis and thrombosis, and anticoagulation is extremely important. And prompt restoration of the sinus rhythm is very important. The antiarrhythmic options are often limited. We won't be able to use amiodarone unless it is absolutely indicated, and electrical coordination may often be required. It is good to have an EP consultation, and EPs have a good role to play in Fontan's arrhythmia. Thrombotic complications are common. Acute pulmonary embolism is poorly tolerated. Anticoagulation is very important. With heart failure, look at the inciting causes of arrhythmia, arrhythmia, anemia, thyrotoxicosis, and watch for the other complications as well. And I think we discussed about, somebody had asked about anticoagulation regimen, why therapeutic anticoagulation. A patient with the fenestration, a patient with atrial arrhythmia, a patient with venous thromboembolism, preferably prior VTE, will need therapeutic anticoagulation. Whereas the rest of the patients in the antenatal period and up to 6 to 12 weeks postnatal period, it is good to have a prophylactic anticoagulation. I just highlighted what is therapeutic, given some examples of therapeutic and prophylactic anticoagulation regimen. And delivery, the last two slides, the vaginal delivery with a shortened second stage labor is the preferred one. Use carefully titrated neuraxial anesthesia to avoid hypotension. They're highly preload dependent, so labor may be conducted in the left lateral decubitus position to avoid caval compression, hypotension. And hypotension we have to be watching for. It is very common with anesthesia, blood loss, and Valsalva. So you can use judiciously IV fluids to support the blood pressure. Watch for arrhythmia, bleeding, and thrombosis. So anticipate postpartum hemorrhage. Use white bore needle, cross-match blood, and active management of third stage of labor. Uterotonics, oxytocin, carefully titrate, avoid rapid IV bolus, avoid carboprost and ergometasin. And anticoagulation for 6 to 12 weeks in cesarean delivery for uncontrolled arrhythmia, uncontrolled heart failure. And this patient, we had a heart failure. And this patient had indications for cesarean delivery. And with that, I thank you. And any queries, any comments, we are open. Otherwise, we'll ask. Any comments here, any queries, any points? Somebody has raised the hands. Jay, Bharati, and Ravi. I'm not too sure. Can you speak now, Ravi? Make it quick. We have last 2 minutes. I don't know. I'm allowing you to talk. You can unmute yourself to talk. Ravi and Jay, Bharati. Or if you can't, just message us.
The issue of infective endocarditis, I think somebody has raised this question. Has it been answered?
I'm not too sure, madam.
Maybe there was a question. Yeah, there was a question that since there is a conduit, should we give infective endocarditis prophylaxis? I think since it has been many years ago, that conduit would have endothelized, so I don't find the need for IE prophylaxis. But I'm sure others can comment on that.
Yeah, Dr. Navaneetha, what about your thoughts? Did you give IE prophylaxis for this patient?
So, sir, we also, think similar to what ma'am was saying. So, essentially, this is a large, like a tube which is connecting the inferior vena cava to the right pulmonary artery, and it was done very long ago. And so now it should be endothelialized, and we do not feel that, like, it is similar to a patch which has been endothelialized. So in that situation, only first 6 months is considered to be high risk. After that, it is not. Unlike right ventricle to pulmonary artery conduit with a valve inside. So in that sense, although this is a conduit, this is different, and I go, in sync with what ma'am is saying, that we did not give IE prophylaxis for this patient.
Dr. Nageswara?
Yeah, but we have a slight difference of opinion. I think in the absence of fenestration, it's a good. But in this patient, fenestration is there, and also AV wall regurgitation is there. So therefore, if there are additional issues like AV wall regurgitation and functioning fenestration, we tend to give endocarditis prophylaxis.
Okay. Any other comments? If not, it's our pleasant privilege to have you all with us. A sincere thanks to Amrita, Dr.Navaneetha, and team for presenting a wonderful case. You really highlighted us and showed to us that a very complex patient like this can be given the opportunity and joy of being a mother, and you have shown how you have supported her through over all this period. Thank you so much for presenting the case, Dr. Navaneetha, and your team and the postgraduate as well. You did a great job. Thank you so much. And our panelists, I sincere thanks to Dr. Manoj, Challani, Dr. Sumitra, Dr. Nageswara. You really filled in all the necessary gaps and you made it whole. Anita ma'am, you are always there for us. Thank you so much for filling in, and your comments are always very, very helpful. And I think you should be there in all the meetings. That's what I feel. Thank you so much, Dr. Anita ma'am. And Annie, I think you have been a asset to us. In the last minute, you made all the changes and included all the panel discussions. You planned the flow in the last 1 hour. Thank you so much for doing that. And our team at GAMI for bringing all these things together. And above all, most importantly, the audience. It is for you and your presence that gives us the motivation to do this job. I'm sure we'll continue to do this. And the next time we are presenting a case of prosthetic valve thrombosis in pregnancy, a complex case managed by Annie. Annie will be presenting the case, a case of prosthetic valve thrombosis in pregnancy, who also had a peripheral emboli and successfully delivered. So we'll discuss that case. And thank you so much, everyone, and God bless you. Thank you so much.
Thank you very much.
Thank you. Thank you so much.
Yeah.